Hello to all of you. Today we will be discussing the questions of anatomy of GT 181, myself Dr. Shilpi Agarwal, and we will continue with the questions. The question number 41 is, it is a image, MRI image, in which it mentions that which of the following structures is indicated by white arrow in the image below. Now this image, if we see, this is an MRI image, this is MRI image and the section is the coronal section. And this is a T1 weighted image. When we see the T1 weighted image, in this T1 weighted image the CSF, it is black in color, the grey matter, it also appears to be black in color or it is dark. The white matter and the fat, it appears to be bright or white in color. It appears to be bright. Now if you see this section specifically, the arrow is put over here. So we will focus this image and we see the arrow is over here. We can see two rounded shadows, and these two rounded shadows are the shadows of the inferior colliculi. Now this coronal section is a section which is taken in a very caudal plane, and it is the two rounded elevations, these are inferior colliculi, and it is continuing below with the superior cerebellar peduncles also, and lower down we can see the image of cerebellum. So as to visualize the pineal body or to visualize the superior colliculi, a more rostral plane is to be taken, a more rostral coronal plane can be taken, and if we see this, this is the coronal plane in which we can visualize the superior colliculi as well as we can visualize the pineal body. Now in this, if we see a rounded, single rounded structure which is present over here in the center, this is the pineal body. This is the pineal body, and just below that the two rounded elevations which are seen over here, these are the superior colliculi. This is the superior colliculus. So this image is a more rostral one, and in this was the inferior colliculi. This was the inferior colliculi. So if we come back to the question, the answer for this question is B, that is the inferior colliculus. This image is through the inferior colliculus. And if such kind of image is given, in that case these two rounded elevations will be the superior colliculus, and just above that a single unpaired elevation or a rounded shadow which is seen over here is the pineal body. For the next question, the question number 42, it is regarding the blood supply to the femoral head. Now before starting the blood supply of the femoral head, we should know that it is basically having, if you see the femur, near the head there is a depression which is known as fovea, and over here there is the attachment of a ligament which is known as the round ligament or ligamentum teres. So if this is the femur, this is the round ligament, or we say it is also termed as ligamentum teres. The capsule is attached over here. The arteries which are entering into the head of the femur through this round ligament or the ligamentum teres, it is known as the artery of the ligamentum teres. So the artery which is entering over here, this is the artery of ligamentum teres, and it is also known as medial epiphyseal artery, and this supplies the area around this fovea. So it is supplying it is forming a minor component of blood supply to the head of the femur, and it is around the fovea. The rest of the portion, that is over here, the rest of the portion is completed by mainly by the arteries which are actually entering into the capsule. The arteries which enter into the capsule over here, these are termed as the retinacular arteries. These are termed as retinacular arteries, and these are also known as lateral epiphyseal artery. The artery which were entering through the ligamentum teres was termed as acetabular artery, also known as medial epiphyseal artery. Now, when we talk about the acetabular artery or the artery to ligamentum teres or known as medial epiphyseal artery, this is in turn a branch of the obturator artery. So, this is a branch of the obturator artery, and for the retinacular arteries which are actually entering through the capsule and then they further supply the rest of the head, these are also known as lateral epiphyseal artery, and they mainly arise from the medial circumflex femoral artery. Now, apart from this, it is also getting supply from the branches of the lateral circumflex femoral artery as well as the branches of inferior gluteal artery. Now, if you see this picture, this is the same same picture which we have just drawn. Over here, this is the fovea region. This is the region of the fovea, over where the ligamentum teres is attached, and the artery which is going through this is the artery of the ligamentum teres. Now, apart from this, we can see just at the base, this is the base of neck of the femur. Near this, a arterial ring is formed which is surrounding the whole of the base of neck. Now, the artery which is giving, or which is forming a arterial ring over here, that is the deep femoral artery or the profunda femoris artery. The profunda femoris artery, it gives off the medial and the lateral circumflex artery. The medial circumflex artery, which is going like this, it goes towards the posterior side. It goes towards the posterior side over here, and it reaches to the superior portion of the neck. So, it is when it reaches towards the posterior superior portion of the neck, it gives the retinacular branches. The retinacular branches which will enter, and it will be supplying the rest of the part of the head of the femur. The lateral circumflex artery, this was the medial circumflex femoral artery, and this over here is the lateral circumflex femoral artery. It is running through the anterior portion of the base of the neck, and it is also giving off the branches, but it is contributing to a minor scale. So, the major contribution is by the medial circumflex femoral artery. Now, over here we can see the medial circumflex femoral artery as well as the lateral circumflex femoral artery, both are the branches of the profunda femoris artery. Though the main contribution is by medial circumflex, but a small contribution is also from the lateral circumflex. So, if in the options both medial circumflex and the profunda femoris is given, we will of course go for the profunda femoris, because these two branches are coming, or are the branches of the profunda femoris artery only. Now, when we talk about this arterial ring, which is present at the base of the neck, this is extracapsular, and this arterial ring, it is formed mainly by medial circumflex femoral artery, and it is towards the posterior side. Then also contributed by lateral circumflex femoral artery, which is on the anterior side. Apart from this, it is also getting contribution from the superior and inferior gluteal artery. Now, if we come back to the question, the question says the blood supply to the femoral head is mostly by the lateral epiphyseal artery. The lateral epiphyseal artery was the medial circumflex femoral artery. Then medial epiphyseal artery is artery to ligamentum teres. It is artery to ligamentum teres. Then we have ligamentum teres artery, which is the same. So, B and C options are same. and lastly is the profunda femoris artery. The answer will be profunda femoris artery because it is in turn giving medial and the lateral circumflex femoral artery, which are then supplying the whole of the head of the femur, and in that too the medial circumflex femoral artery is majorly supplying. So we will go for the best answer, and that is the profunda femoris artery. So the answer for question number 42 is D. For the question number 43, it says that after the removal of parotid gland, so it is regarding the parotid surgery, the patient is having sweating on cheeks while eating. In this complication, seen after parotidectomy, the auriculotemporal nerve, which contains parasympathetic secretomotor fibers to parotid gland, is fused with which nerve? Now this is a clinical condition known as Frey syndrome. In this Frey syndrome, what happens when the parotid gland is dissected, or it is the surgical operation is done on that, then in that case auriculotemporal nerve can be damaged in few cases, and if it is damaged, then while it is recovering or while it is regenerating, few of the parasympathetic fibers which are present in the auriculotemporal nerve may regenerate and they fuse with the great auricular nerve. And due to that fusion, what happens when there is a stimulus for the eating, when the eating stimulus is there, the stimulus passes through the parasympathetic fibers and it should go towards the salivary glands. But apart from that, it also goes through the great auricular nerve to the sweat glands. So therefore we observe sweating on the cheeks. Let us see that how this is happening. Now if you see this picture, in this picture this is the normal, and this is the normal A, and B shows the condition of the Frey syndrome. Now in the normal condition, if we see the parasympathetic fibers, they are simply running and they are going to the parotid gland, and these parasympathetic fibers are carried through the auriculotemporal nerve. Then the sympathetic fibers which are going towards the sweat glands, they are carried by the great auricular nerve. Now if the injury to the auriculotemporal nerve is there and when it is regenerating, few fibers of the parasympathetic, they which are going already to the parotid gland, they also fuse with the great auricular nerve over here, and therefore they will be going to the sweat glands also. So when we eat something, the parasympathetic fibers are stimulated and the stimulus, it is going to the parotid gland for the secretion of the saliva, and along with that the stimulus is going to the sweat glands also, due to which the sweating can be observed in the area of distribution of great auricular nerve. So if you see this picture over here, the great auricular nerve, it is supplying the area or the skin around the angle of mandible over here. So in this area the sweating is observed, as well as along with that the flushing is observed. So if we come back to the question, the auriculotemporal nerve, it fuses with the great auricular nerve, and the answer for this question is C. Question number 44, it says that surgical markings for findings of facial nerve. This is again regarding when we are doing any operation in the parotid region, we are doing parotid dissection or parotid surgery is there, then we should have some landmarks which are consistent and anatomically consistent, as well as which can be easily found, so that we are able to localize the facial nerve during live surgeries. Now if we talk about it, first of all we will just see the landmarks which are present in the temporal bone. This is the temporal bone. Now over here if we see, this is the tympanic portion of the temporal bone, and this is the mastoid portion of the temporal bone over here. This is the mastoid portion and this is the tympanic portion. Above we have the squamous portion. Now in between the tympanic component and the mastoid component, there is a suture which is known as tympanomastoid suture. So this is the location of the tympanomastoid suture. Then we see a projection which is going down. This is a styloid process. The mastoid portion, it is having an elevation over here or a process over here which is termed as a mastoid process. This is a mastoid process. Just deep to the styloid process, we are having the stylomastoid foramen. Over here, the location of the stylomastoid foramen is over here. So this is the location for the stylomastoid foramen. And through the stylomastoid foramen, the facial nerve, it exits out. The facial nerve, it comes out through this stylomastoid foramen. So if we see same thing in this diagram, we can visualize this is the facial nerve. This is the facial nerve which has been shown to be coming out through the stylomastoid foramen, and it is in when we are doing any surgery in this area, we can localize the facial nerve with the help of these surgical landmarks which are present around. So one of the important landmark is the tympanomastoid suture which is present over here. Apart from this, another landmark is the digastric muscle. If you see over here, this is the digastric muscle which has been shown, the digastric muscle which is attached to the mastoid process. And then the third important landmark is the tragal pointer. These are the three important landmarks. So if you just see this picture, the three important landmarks are tympanomastoid, then we have tragal pointer and the posterior belly of digastric. Now if you, with the help of these landmarks, if you try to visualize or try to localize the facial nerve, when we see the tympanomastoid suture, the facial nerve is lying 6 to 8 mm deep to this suture. For the tragal pointer is near the tragus of the ear. The facial nerve lies 1 centimeter anterior inferior medial to it, to this tragal pointer. The third is the posterior belly of digastric. The facial nerve is lying 1 centimeter superior to it, as well as it lies parallel to the upper border of the posterior belly of digastric muscle. So these are the three important landmarks, and among this, the most important, most useful and the most important is the posterior belly of digastric. So these are the three landmarks, and apart from this we have others also, and which includes the styloid process. The facial nerve is lying lateral to the styloid process, and there is a groove between the mastoid process and the bony external acoustic canal which is bisected by the facial nerve. So these are the surgical landmarks. When we are doing the surgery, we can just see that how we can visualize it. The structure which can be seen over here, this is the main trunk of the facial nerve, which is further going into the parotid gland, and it will be dividing into the further branches. And in its course, it is related to important structures. One is the cartilage pointer, that is the tragal pointer. Then we have the styloid process also, tympanomastoid suture, the digastric muscle which is present over here. So if we come back to the question now, the surgical markings for the findings of facial nerve are, all the three are the surgical landmarks. So the answer for this question will be all of the above. And apart from this, we also include the mastoid process as well as the styloid process as a surgical landmark. For the next question, the question number 45. It says that all the following structures pass through superior aperture of the thorax. Now, when we talk about the superior aperture of the thorax, if you visualize this picture, the superior aperture of the thorax is also termed as the thoracic inlet. The thoracic inlet, this is the portion where the thoracic inlet is present, and it is formed anteriorly by the manubrium portion of the sternum. This is the manubrium portion of the sternum. On the lateral sides, it is formed by the first rib, the inner border of the first rib, and towards the posterior side, it is formed by the first thoracic vertebra. So these are the structures which are forming the boundaries of the superior thoracic aperture or the thoracic inlet. Through the superior thoracic aperture, whatever structures are present in the neck, they will enter into the thoracic region. and then at the lower portion we are having the inferior thoracic aperture. The inferior thoracic aperture entirely it is bounded by the xiphoid process, or we can say the lowermost portion of the sternum over here, then the subcostal margin and the lowermost rib, that is the 12th rib over here, and posteriorly the 12th thoracic vertebra. So this is also termed as the thoracic outlet or the inferior thoracic aperture. Now if we talk about the superior thoracic aperture, the structures present in the neck, they pass through this superior thoracic aperture. Now in this we are mainly concerned that which structure is not passing through it. We can see in this diagram that mainly all the structures are passing over here. If we focus on the recurrent laryngeal nerve, this is the right recurrent laryngeal nerve, and over here the left recurrent laryngeal nerve. The left recurrent laryngeal nerve, it is present over here. It runs in the tracheoesophageal groove and it is passing through the superior aperture and it goes below, and when it is going below, it goes towards the superior mediastinum, then it winds around the arch of the aorta and then it comes back into the neck. So this structure is passing through the superior aperture. But if we talk about the right recurrent laryngeal nerve, which is present over here, it actually winds around the right subclavian artery, which is present over here. This is the right subclavian artery, which is going like this. So this right recurrent laryngeal nerve, it winds around it and it goes above. So we can visualize in this diagram that the right recurrent laryngeal nerve, it is not entering the superior aperture and it is not going into the mediastinum. In the neck only it surrounds or it winds around the right subclavian artery and it then ascends upwards. Then what are the structures which are actually passing through this superior aperture, or we say through the thoracic inlet? Now the viscerals which are passing through it, we can visualize over here the esophagus and the trachea. The esophagus and the trachea, it is passing through the superior aperture and it becomes the content of the superior mediastinum. Apart from this, a lymphatic vessel, that is the thoracic duct, it is also present over here, or it is passing through the superior aperture. Then the apex of the lungs, which is on the lateral side, the apex of the lung, and in the anterior portion the part of the thymus, this is the thymus. So these are the viscerals which are passing through the superior aperture. Then if we talk about the vessels, so first of all the arteries, the major arteries which are passing through it are the brachiocephalic artery, which is on the right side. This is the brachiocephalic artery. Then we have left subclavian artery and the left common carotid artery. These are the major arteries, and apart from that we have superior intercostal artery, which is present on right and the left side. This is the superior intercostal artery over here, which is present on the right and the left side both. Then on the anterior side we have the internal thoracic artery. This is the internal thoracic artery, right and the left side. So all these are the vessels which are arteries which are passing through the superior aperture. If we talk about the veins, we can very well visualize the right and the left brachiocephalic vein. The right and the left brachiocephalic vein, as we go more posteriorly over here, on the right and the left side we have posterior intercostal, the first posterior intercostal veins. Then apart from this, inferior thyroid vein, which is present over here, the right and the left inferior thyroid vein. Now regarding the nerves which are passing through the superior aperture, the nerves which are passing over here, if we visualize on the anterior side, this is the phrenic nerve present on right and left side, and along with that the vagus nerve. This is the vagus present on the right and the left side. So right and the left vagus and the phrenic nerve. Apart from this, on the posterior aspect we have first thoracic nerve, and over here the sympathetic chain, which is also present towards the right and the left side. So all these structures are the structures which are passing through the superior aperture or the thoracic inlet to enter or they are either entering the mediastinum or they are coming out of the mediastinum. So if we come back to the question now, the question says that all of the structures, they pass through the superior aperture of the thorax except, so in this The answer for this question will be right recurrent laryngeal nerve, because it winds around the right subclavian artery before entering into the superior aperture, and then it ascends in the neck. The left common carotid, left sympathetic trunk, as well as the thoracic duct, all these structures are passing through the superior aperture, as we have just discussed. Now the next question, it is an image based question. It says that the arrow marked area is supplied by which nerve? This is the arrow marked area. If we see, this is a picture of the foot, and the arrow is marked over the first web space in the foot. Now this first web space of the foot, it is characteristically supplied by the deep peroneal nerve. It is characteristically supplied by the deep peroneal nerve, and the answer for this question is D. If we see the rest of the areas, the rest of the portion of the foot over here, it is supplied by the superficial peroneal nerve. And if we visualize towards the most medial border, the medial border is supplied by the saphenous nerve. And towards the lateral border, it is supplied by the sural nerve. So the saphenous nerve, sural nerve, the superficial peroneal nerve, and the deep peroneal nerve, they all are supplying the dorsum of the foot, and the medial plantar nerve, which has been mentioned over here, it is actually supplying the sole of the foot. Now if we visualize, or if we discuss the cutaneous supply of the whole of the lower limb, we can very well see, first of all we will just see the thigh portion. In the thigh portion, in this area, this is the skin which will be covering the femoral triangle. So if you see the medial portion of the femoral triangle, the skin over that is supplied by the ilioinguinal nerve, and towards the lateral side over here, the skin which is covering the lateral portion of the femoral triangle is supplied by the genitofemoral nerve, and in this specifically the femoral branch. Now the rest of the portion of the thigh, on the most medial side, we can see over here, this area is supplied by the obturator nerve. The obturator nerve is basically supplying the middle portion of the medial side of the thigh. The rest of the medial portion over here, the rest of the medial portion as well as the anterior portion, it is supplied by the anterior cutaneous nerves, which are given off by the femoral nerve, and these are namely the medial and the intermediate cutaneous nerve of the thigh. Towards the most lateral side, over here, as well as it is slightly towards the lateral as well as towards the anterior. The anterior lateral portion of the thigh, it is supplied by the lateral cutaneous nerve of the thigh. As we reach towards the leg area, in the leg area, towards the medial side, this is the medial side, towards the medial side, the whole of the leg is supplied by the saphenous nerve, and this supply is continuing till the medial border of the foot. Towards the lateral side, the upper portion, the upper half of the lateral side, it is supplied by the lateral cutaneous nerve of the calf, and the lower portion is supplied by the superficial peroneal nerve. The superficial peroneal nerve, and this is continuing in whole of the foot in so the major supply to the skin of the foot is by the superficial peroneal nerve. Towards the most lateral border, we have already discussed, it is supplied by the sural nerve. Now if we come towards the posterior surface of the lower limb, we can very well see that the nerves which are supplying the anterior portion, which are towards the most medial and the lateral side, they are also supplying the medial and the lateral portions of the posterior aspect. And apart from that, a nerve, the main nerve which is supplying the posterior aspect of thigh as well as the skin over the popliteal fossa, along with that the inferior portion of the buttock also, that nerve is the posterior cutaneous nerve of thigh. The posterior cutaneous nerve of thigh. As we come below, we can see towards the heel portion. Towards the heel portion is being supplied by the calcaneal branches, which are given by the tibial nerve, and if you see the sole, the heel is supplied by the calcaneal branches of the tibial nerve. Along with that, towards the most medial side, the nerve which is supplying it is the medial plantar nerve, which is in turn a branch of the tibial nerve only, and towards the lateral side we have the lateral plantar nerve. The lateral plantar nerve is also a branch of the tibial nerve, and when we go towards the toes, the medial plantar nerve, it is supplying the medial 3.5 toes, and the lateral plantar nerve, it is supplying the lateral 1.5 toes. Along with it, it is also supplying the nail beds also. For that means that medial plantar nerve, it supplies the nail beds of medial 3.5 toes. The lateral plantar nerve, it supplies the nail beds of lateral 1.5 toes. So this is the complete cutaneous supply of the lower limb, and the answer for this question, the arrow mark is specifically on the first web space. The answer is the deep peroneal nerve, that is D. Now the next question is question number 47. It says that a patient with external hemorrhoids develops pain while passing stools. The nerve mediating this pain is. Now if we talk about the hemorrhoids are basically the saccular dilatations of the veins which are supplying the anal canal, or which are draining that portion of the anal canal. Now if you see the anal canal is divided into two major portions with the help of a line termed as pectinate line. The pectinate line is passing over here, the pectinate or the dentate line. Now the portion of the anal canal which is above the pectinate line or the below the pectinate line, they are completely different in the terms of its nerve supply as well as its arterial and the venous supply and the lymphatic supply, because embryologically they are developed from the different structures. Now whatever saccular dilatations, if they occur in the venous plexus below the pectinate line, then we use the term as the external hemorrhoids, and these are also known as false piles. If the venous sacculations or the dilatations are present above the pectinate line, as we can see over here, this one, this is the internal hemorrhoids, and it is also known as true piles. If you just see the anatomical structure over here, again this line over here, this is the pectinate line, this is the pectinate line, and if you see the nerve supply above the pectinate line, the nerve supply of the anal canal above the pectinate line is by the autonomic nervous system, that it is having a sympathetic as well as the parasympathetic fibers which will be supplying it. So these are the nerves which are supplying the region above it. For the sympathetic we are having L1, L2, and for the parasympathetic we are having S2, S3 and S4. For the area which is below the anal canal, the nerve supply is by the somatic nerve and specifically by the inferior rectal nerve. The inferior rectal nerve, it is a branch of the pudendal nerve. So this is regarding the nerve supply of the anal canal. If we talk about the arteries, the area above the pectinate line, it is supplied by the superior rectal artery which comes from the inferior mesenteric, and the portion below the pectinate line, it is supplied by the inferior rectal artery which is a branch of the internal iliac artery. Regarding the venous supply, the veins which are draining the upper portion above the pectinate line is the superior rectal veins which basically go towards the portal venous system. The area below the pectinate line is drained by the inferior rectal vein which will go towards the caval venous system. Regarding the lymphatics above the pectinate line, they reach to the internal iliac lymph nodes, and below the pectinate line they go towards the superficial inguinal lymph nodes. So over here we can see that the nerve supply is different in the anal canal. So that is why if the hemorrhoids, they are present above the hemorrhoids which are present above the pectinate line, that is the internal hemorrhoids or the true piles, they will be supplied by the autonomic nervous system fibers, that is the parasympathetic and the sympathetic fibers, and these fibers, they are insensitive to pain. So due to this, the true piles or the internal hemorrhoids, they are painless. Due to this reason they are painless, And if we talk about the external hemorrhoids, they are present below the pectinate line. So, and they are supplied by the inferior rectal nerve or the somatic nerve, which is actually a branch of the pudendal nerve, supplied by pudendal nerve, the inferior rectal nerve, and these type of piles, they are painful, they are extremely painful. So, if you come back to the question over here, question talks about the external hemorrhoids and it asks that the nerve which mediates this pain, the answer for this question will be B, that is the pudendal nerve, because the area the external hemorrhoids, they are supplied by the inferior rectal nerve, which is in turn a branch of the pudendal nerve. Now, if we talk about the internal hemorrhoids, the internal hemorrhoids or the true piles, they can be the internal hemorrhoid or the true piles, they can be primary piles or secondary piles. The primary piles are specifically at the location, at the three locations, that is 3 o'clock, 7 o'clock and 11 o'clock position. If you just visualize over here, if this is the anal canal, towards here this is the anterior side, this is the posterior side, this is the right and the left. Then if the hemorrhoid is present over here, this is the 3 o'clock position, this is the 3 o'clock position, it is also termed as right, the right sided hemorrhoids, it is present on the right side. The 7 o'clock, it is present over here, this is the position for the 7 o'clock and it is also known as posterior lateral hemorrhoids. These are also known as left posterior lateral hemorrhoids, and this is the position for the 11 o'clock hemorrhoids, and this is also known as the left and the posterior anterior. They are present towards the anterior side, so they are also known as anterior lateral hemorrhoids. So, any hemorrhoids which are occurring at either the 3 o'clock position, 7 o'clock or the 11 o'clock position, they are termed as the primary piles, and if the piles are occurring at any other location, they will be included or they will be termed as the secondary piles. And as we have already discussed, these are the painless and they bleed profusely if the straining is there during defecation. For the external hemorrhoids or the false piles, these are extremely painful. Now, if we talk about the veins which are actually draining it and due to which dilatation these hemorrhoids are occurring, if we talk about these veins, we are basically having the main venous plexus, which is present over here is the internal rectal venous plexus, and it is submucosal in position, the internal rectus venous plexus. Apart from this, we also have external rectal venous plexus, and the external plexus, it is present outside the muscular coat of the rectum. The internal rectal plexus, it is mainly drained by the superior rectal vein. Over here if you see the superior rectal vein, and the superior rectal vein in turn drains into the inferior mesenteric vein. Apart from this, the external venous plexus, the rectus venous plexus, it is drained by three veins. In the upper portion, it is drained by the superior rectal vein. In the middle portion, it is drained by the middle rectal vein. The middle rectal vein, it will in turn go towards the internal iliac vein. In the lower portion, it will be drained by the inferior rectal vein. The inferior rectal vein, it goes through the internal pudendal vein and then finally into the internal iliac vein. These are the various hemorrhoid veins, and in this the superior rectal vein, it is termed as superior hemorrhoidal vein. The middle rectal vein is termed as middle hemorrhoidal vein, and the inferior rectal vein, it is termed as inferior hemorrhoidal vein. So, these are the various hemorrhoidal veins which are present in the portion of the rectum and the anal canal and its venous drainage. Now, for the next question, question number 48, the marked structure in this picture is due to the defect in. Now, if you see the marked structure over here, this marked structure is the superficial inguinal ring. This marked structure is superficial inguinal ring, and this superficial inguinal ring, it is a gap which is present in the aponeurosis of external oblique muscle. So, the answer for this question is A, that is external oblique. Now, if you see the various layers, as well as if you see visualize this picture again. Now the muscle which is present over here, the external oblique muscle, as it is coming towards the medial side, it becomes aponeurotic, and a gap is created over here just above the pubic tubercle, and this gap is known as external or the superficial inguinal ring. This is actually through this, the structures which are passing through the inguinal canal, they will exit out through this superficial inguinal ring. Just corresponding to it, we have a internal inguinal ring or the deep inguinal ring, which is actually a defect or a gap in the fascia transversalis, and in between the superficial and the deep inguinal ring we have the inguinal canal. This is the inguinal canal which is present over here. This hole is the inguinal canal present between the deep and the superficial ring, and the structures, they pass through this inguinal canal and then they come out. The structures which are passing through the inguinal canal are the spermatic cord in the males and the round ligament in the females. Along with that, the ilioinguinal nerve is also passing or through the inguinal canal. It is not entering through the deep ring, but it exits through the superficial ring, only the ilioinguinal nerve. The structure which passes through whole of the inguinal canal is either the spermatic cord or the round ligament. Now if you see in this, we have already discussed that the superficial ring is a defect or a gap in the external oblique aponeurosis towards the lower side. Towards the lower side, this is the lower margin of the external oblique muscle. It takes a in-turn and it forms a thickening known as inguinal ligament. The thickening, it is the inguinal ligament, it is the interned or it is a turned portion of the lower margin of external oblique aponeurosis. So it is also derived from the external oblique aponeurosis. Now over here if you see the various layers in the abdominal portion as well as the muscles which are contributing to the walls of the inguinal canal. The outermost muscle is the external oblique muscle. This is external oblique muscle, then internal oblique. This is transversus abdominis, this is fascia transversalis, and this is the peritoneum. The superficial ring is present over here. This is the portion where the superficial ring is present and the deep ring is present over here. The superficial ring, as we can see, it is a defect in the external oblique aponeurosis, and this is the location of deep ring. This is present in the fascia transversalis. The portion in between over here, this hole is the inguinal canal. Now when we talk about the inguinal canal, the structures which are making the anterior wall of the inguinal canal, these are the mainly it is formed by the external oblique muscle, and on the lateral side it is contributed over here by the internal oblique muscle also. So the structures which are forming the anterior wall are external oblique aponeurosis and the internal oblique muscle. Now if we see towards the posterior side, this is the posterior side over here. The structure which is forming the posterior wall of the inguinal canal is the fascia transversalis. So for the inguinal canal, the anterior wall is formed by mainly by the external oblique as well as contributed by the internal oblique also. Towards the posterior wall, the posterior wall is mainly formed by the fascia transversalis. Then the roof. The roof is mainly contributed by the internal oblique and the transversus abdominis fibers, which are basically binding or which is turning over the inguinal canal. So the internal oblique over here and the transversus abdominis, they go over, they form the roof of the inguinal canal, and then they reach towards the medial side, and on the medial side they form the conjoint tendon. Towards the floor is formed by the inguinal ligament. The floor is formed by the inguinal ligament. The inguinal ligament which is present over here, it is forming the floor of the inguinal canal, and on the medial side over here, on the medial side it forms the lacunar ligament which is contributing to the floor. For the deep inguinal ring is lying around 1.25 centimeter above the mid inguinal point. So the answer for this question is the external oblique, and the arrow marked structure is superficial inguinal ring. For the next question, the question number 49, it says that all the following arteries are supplying the medulla oblongata. So first of all, we will just see that which arteries are supplying the medulla oblongata. If you see this picture over here, we already know that the two vertebral arteries, they enter from either side. These are the vertebral arteries. This is the vertebral artery. It enters through the foramen magnum from either side, and then it unites to form the basilar artery. This is the vertebral artery, and it forms this basilar artery. This is the basilar artery. The vertebral artery, it is in relation with the medulla, and at the basilar artery, it is in the relation with the pons. Then this basilar artery, it terminates into the posterior cerebral artery. During this course, it is giving various branches. The vertebral artery is giving the anterior and the posterior spinal arteries, and along with that, it is giving a pica branch, that is the posterior inferior cerebellar artery. If you visualize it over here, this is a lateral view. The vertebral artery, which is running over here like this, it is giving a pica branch going above over here, and during its course, it is supplying the medulla portion also. The anterior spinal artery, which goes anteriorly, it is also supplying the medulla when it is passing below to the spinal cord. Apart from this, a posterior spinal artery is also given, which supplies some portion of the medulla. This is the cut section of the medulla. In this, we can see the main supply to the medulla is by anterior spinal artery. The anterior spinal artery, it is supplying the medial portion of the medulla. Then the lateral portions of the medulla, it is supplied by the pica or the posterior inferior cerebellar artery. The portion in between these two is supplied by the vertebral artery. And some area is also supplied by the posterior spinal artery towards the most posterior side. So these are the main arteries which are supplying the medulla, and along with that, some contribution is from the basilar artery also. So if you come back to the question now, the question says that all our arteries are supplying the medulla except the posterior inferior cerebral artery, it is supplying the anterior spinal artery, along with that posterior spinal artery also, and the vertebral artery also. AIIMS is not supplying the medulla oblongata, so the answer for this question will be C, that is the anterior inferior cerebellar artery. The next question, the question number 50. The question number 50 says that which of the following marked structures will continue as content of middle mediastinum. Now this section is through the neck over here, and we can visualize the deep fascia, the various layers of the deep fascia in this, and if you see the structures which are being marked over here, the structure A over here, it is within the carotid sheath. This structure is the vagus nerve. The structure B over here is the phrenic nerve. The structure C is sympathetic trunk. The structure D, it is a lymph node which is present over here. Apart from this, if you visualize other structures, this is the investing layer of the deep fascia. This is the carotid sheath. This is the pretracheal layer, and this is the prevertebral layer of the deep fascia. The pretracheal layer, it is enclosing the thyroid gland. This is the thyroid gland, as well as along with that the trachea is there and the esophagus is there. Then the carotid sheath, it is enclosing the main structures. One is the vagus nerve. Apart from this, we are having this vein, which is the internal jugular vein, and the artery which is present over here is the common carotid artery. The sympathetic trunk, it is related to the posterior wall of the carotid sheath. The prevertebral layer, it is consisting of, or it is actually surrounding all the pre and the paravertebral muscles, and the investing layer, it is enclosing two muscles mainly. This is the sternocleidomastoid muscle and this is the trapezius muscle. Apart from this, we can visualize a vein over here. The vein which is present over here, this is the external jugular vein. This is the external jugular vein. Now, if we see that which structure among these four A, B, C, D will continue as a content of the middle mediastinum. In this, the structure which will continue in the middle mediastinum is the phrenic nerve. Out of vagus nerve, phrenic nerve, sympathetic trunk and the lymph node, the phrenic nerve is the structure which is forming one of the contents of the middle mediastinum. So, therefore, the answer for this question will be B, because B is the phrenic nerve. Now, if we talk about the mediastinum, the mediastinum is the space between the two lungs and it is divided into superior and the inferior mediastinum at the level of the sternal angle, which is at the level of, at the lower border of the fourth thoracic vertebra. So, this is the sternal angle. The sternal angle is between the manubrium portion of the sternum and the body of the sternum. Now, this inferior mediastinum, it is again divided into three portions. The portion which is consisting mainly of the heart is termed as the middle mediastinum. The space which is present anterior to the middle mediastinum is anterior mediastinum, and the posterior space, or we can say the space which is behind the heart, is the posterior mediastinum. So, inferior mediastinum, it is having subdivisions which are anterior mediastinum, middle mediastinum and the posterior mediastinum. And if you see, the middle mediastinum is mainly having the heart and the pericardium, and along with that the other structures. Now, if you see the picture over here, in the middle mediastinum, the main structures which are present over here, the heart and the pericardium. These are the main structures which are present over here, and along with that we can see the nerve which is running along with it. This is the nerve, this is the phrenic nerve which is coming from the neck and it is going below to the diaphragm. The phrenic nerve, it is present in the middle mediastinum. Then we can see the middle mediastinum, it is also consisting of the ascending aorta. The ascending aorta, then the pulmonary trunk along with the branches of the pulmonary trunk, and the lower portion of superior vena cava. Apart from this, the thymus gland is also having some portion which, sorry, not thymus gland, only this one. These are the structures which are present in the middle mediastinum. If you see in this picture, we can very well visualize that this is the line for the stern which is passing through the sternal angle, and the structures which will be present over here, in between over here, these are the structures in the middle mediastinum. So, the ascending aorta, this is the ascending aorta portion which is lying in the middle mediastinum, as well as the pulmonary artery along with its divisions. The structures which are present above this are the contents of the superior mediastinum. So, the contents of superior mediastinum, it will include the arch of aorta, along with that its branches, that is brachiocephalic artery, common carotid, the left common carotid and the left subclavian artery, along with that upper portion of superior vena cava and the right and the left brachiocephalic veins. These are the structures which are present or are the contents of superior mediastinum. Along with these structures, another structures are trachea. This is the trachea. Then we also have esophagus, and the thymus portion is present anteriorly over here. Then the thoracic duct is also there. In the nerves, the vagus nerve, phrenic nerve and the sympathetic trunk, all these nerves and along with it the cardiac nerves are also forming the content of the superior mediastinum. If we talk about the anterior mediastinum, in the anterior mediastinum, the contents of the anterior mediastinum, some portion of the thymus, or we say the lower portion of the thymus is included in this. Then the sternopericardial ligaments. the sternopericardial ligament. Then along with that the mediastinal branches of internal thoracic artery. Then along with that we are also having lymphatics and the lymph nodes which are present in the anterior mediastinum, and it is filled with the adular tissue. So these are the contents of the anterior mediastinum. If you visualize the posterior mediastinum, the structures which are present towards the posterior side, these are the structures which are present in the posterior mediastinum, and mainly the structures in this are thoracic duct, azygous vein, accessory hemiazygous vein and hemiazygous vein. Along with that we can see the sympathetic trunk which is running on the either side of the vertebral column, and the esophagus will be running over here towards the most posterior side. So the contents of the posterior mediastinum, for the contents of posterior mediastinum, it includes esophagus, then descending aorta, along with that the thoracic duct, then the venous system which includes the azygous vein, the hemiazygous vein and the accessory hemiazygous vein, sympathetic trunk along with the splanchnic nerves. Then on the posterior side the posterior mediastinal lymph nodes are also included in this. So these are the structures which are the main forming the main components or main contents of the posterior mediastinum. So if you come back to the question again, now we are clear with all the divisions of the mediastinum as well as the contents in all mediastinum, in the superior mediastinum, in the three subdivisions of the inferior mediastinum, that is anterior, middle and the posterior mediastinum, and the phrenic nerve is the structure which is passing through the middle mediastinum. So the answer for this question is B, that is phrenic nerve. So thanks to all of you for your for the cooperation. Thanks to all of you.